MCAT 2017 Cram, Biochemical and Biological Foundations of Living Systems. Passage 18, Signaling in Staphylococcal Toxic Shock Syndrome. As you view the reading of the passage, you'll notice some highlighted snippets of text. What I want you to do is garner meaning from these specific selections in order to answer the questions that follow. Good luck and happy reading. Paragraph 1. Staphylococcus aureus, as shown here, causes a multitude of toxin-mediated diseases, including staphylococcal scale skin syndrome, SSSS. Okay, here we see it presented on an infant. Toxic shock syndrome, the condition most people are probably familiar with, and food poisoning. These conditions are caused by proteins called superantigens, SAGs for short. Here we see the superantigen, okay, interacting with the T cell. S. aureus can colonize mucosal surfaces such as the mouth or vagina. Although of all colonizing organisms, only about 5 to 10% produce SAGs. In TSS, toxic shock syndrome, Toxin 1, TSST1, interacts with T cell receptors, as shown here, to induce T cell proliferation and massive cytokine production, all shown here in this illustration, which leads to fever, rash, skin peeling, fluid leakage from blood vessels, and resultant hypotension. This condition can be fatal if not diagnosed and treated in a timely fashion. Paragraph 2. TSST1 is a simple 12 amino acid folded protein, as shown here, with a signaling molecule at the carboxy terminal domain that can be cleaved off. When staphylococci come in contact with a mucosal surface, they secrete alpha cytolysins, okay, as shown here, which disrupt the mucosal barrier, as seen here in figure 1. This allows TSST1 to reach the deeper mucosal layers, where T cells reside. TSST1 binds non-specifically to T cell surface receptors. This binding causes T cells to become activated and release highly inflammatory molecules such as interleukin-1 and tumor necrosis factor, TNF, and IL-1 for short, beginning the cascade of clinical TSS symptoms. Researchers have demonstrated that genetic variations in T cell binding to T1 may determine the severity of an individual's disease. Paragraph 3. Treatment of TSS involves an antibiotic course, provision of fluids, and intravenous immunoglobulin, IVIG for short. IVIG is purified antibody. So when some of you go to blood drives and donate blood, this is one of the products that you can sequester from it. So IVIG is purified antibody collected and pooled from multiple donors. It acts to neutralize TSST1. In some toxin-mediated staphylococcal infections, a second antibiotic, clindamycin, is added to the treatment regimen for its anti-protein synthesis effects. With these treatments, mortality from this once uniformly fatal disease is now less than 25%. Figure 1. Inflammatory cascade in toxin-mediated staphylococcal infections. So here you see the TSST1 antigen binding, the release of alpha toxins, tumor necrosis factors, and interleukins. And it's penetrating the mucosal barrier and setting off a T cell cascade. All right. As part of TSS treatment, IVIG serves to A. Restore mucosal barriers, B. Reduce vascular leakage and hypotension, C. Enhance T cell proliferation, or D. Aid the immune system in eliminating Staphylococcus aureus. I'll give you a moment to decide. All right. Okay, so let's just cut to the chase with this one. IVIG doesn't restore mucosal barriers, nor does it enhance T cell proliferation. If you recall from the passage, IVIG's aim would be to neutralize TSST1, therefore halting the resultant inflammatory cascade shown here that causes vascular leakage, when the neutrophils enter and exit, and the hypotension. All right? Okay. When comparing two patients with TSS, the patient with higher affinity T cell binding to TSS T1 would most likely require, and remember this is the toxic shock syndrome, toxin 1. So they would most likely require A. A longer course of antibiotics, B. More intensive rehydration, C. Higher dose antibiotics, or D. Lower dose IVIG. I'll give you a moment to think and decide. This one is a little tricky, so be careful. All right. Okay, so the patient in question has obviously a more pronounced response to TSST1. Antibiotics, they eliminate the causative pathogen, but they don't always ameliorate the toxin-mediated processes, okay, that have occurred. Nowhere in the passage does it mention that a higher dose or a lower dose IVIG provide a really good therapeutic option. Okay, so this is out, this is out, and this is out. So by default, we see that answer choice B is the correct answer choice. And so basically, a more pronounced response to the TSS T1 would require more supportive care, and a form of supportive care is going to be a more aggressive fluid resuscitation. All right? Okay. The rationale for adding clindamycin to a TSS treatment regimen is A. Additive effects of two antibiotics enhancing bacterial killing, B. Neutralization of TSS T1, C. Halting the translation of the TSS T1 protein, or D. Impairing binding of TSS T1 to T cell receptors. I'll give you a moment to decide. All right. Okay, so clindamycin does not neutralize TSS T1. Answer choice B is out. The passage mentions that the purpose of administering IVIG is neutralization. Neither does clindamycin have an effect on the binding of TSS T1 to T cell receptors, as pictured in Figure 1 if you want to see what this looks like. Clindamycin's anti-protein synthesis effects, this is what the passage mentions, halts the production of TSST1. Specifically, it stops the translocation of the protein extra ribosomally, I guess, because there's certain signal sequences in the protein chain that signal, the release of this protein, but clindamycin halts this process with the intent of interrupting the downstream inflammatory effects of the protein. Hence, the correct answer choice is halting the translation of the TSST1 protein. Although this may be a faux pas because specifically it's not halting the translation, is halting the translocation. But I'm not going to argue with the test makers. So, yeah, this is the closest to correct answer choice, okay? The other ones are just pretty far off. A researcher is developing a synthetic neutralizing antibody to treat TSS. The researcher could target all of the following molecules except cytolysine, which may be an aspect of the alpha toxin, B, TSST1, so the toxic shock syndrome toxin 1, um, C, T cell receptors, or D, interleukin 1. So here goes the interleukin 1 out, beta, and and here as well. All right, so I'll give you a moment to decide. Okay. Okay, so neutralizing cytolysine would prevent invasion of TSST1. So this is a potential target for a new treatment. Okay, answer choice A is out. Targeting the TSST1, the toxin itself, or the downstream inflammatory molecules like the interleukins might aid in TSS treatment as well. The researcher could not reasonably block T cell receptors because doing so would also block the beneficial immunologic functions these cells provide in other cases of infection. Okay? All right.